Okay, good morning everyone. Today we'll continue with our musculoskeletal presentations with Dr. Shanga. She will present the cartilage forming lesions.
Assalamu alaikum. Today I will explain some topic about cartilage forming lesion. Starting with synovial osteochondromatosis. Synovial osteochondromatosis is a non-neoplastic synovial metaplasia characterized by formation of intra-articular lobulated cartilaginous nodule, which may ossify or not. It usually monoarticular disorder. Cartilaginous foci, when it is ossified, it's called osteochondromatosis. Synovial proliferation can not directly cause or arthropathy, although intra-articular nodule may cause mechanical erosion and secondary osteoarthritis. Most common location for the synovial osteochondromatosis is the knee. However, shoulder and the hip and elbow also may be affected. In the X-ray, what we see in the X-ray show multiple round intra-articular body of similar size, variable mineralization. Primary differential diagnosis for intra-articular is osteophyte of the osteoarthritis. The first differential diagnosis after the osteochondromatosis. This is for in the X-ray. And when we see the erosion, it is difficult to diagnose it. However, in osteophyte is variable in size, the osteophyte. This is what we see in this X-ray at the biceps tendon.
You can see there are multiple rounded dense lesions of almost same size.
Yes.
While in osteophytes of osteoarthritis, they will tend to be variable in size. And usually they tend to be more calcified than this. Usually.
However, and erosion also
of course,
more.
Yes. Erosion, osteoarthritis by default.
Yes. But in the MRI, appear variable calcification, mineralization is variable. So the first differential diagnosis in the MRI is villonodular pigmentation. But in the villonodular pigmentation,
polypigmented villonodular synovitis.
Yes, pigmented villonodular synovitis. So we can differentiate it as we see in the last session. The erosion and effusion is more in the pigmented villo. Yes.
Okay. Last presentation we saw a case
Yes.
of elbow. It was exactly like that. This is typical feature of synovial osteochondromatosis.
Yes. The second topic is enchondroma. Enchondroma is a benign lesion of mature hyaline cartilage rest. The most commonly affect the long bone and characterized by the characterization in the X-ray is popcorn ring or arc calcification is the most common appearance of it. The differential diagnosis of enchondroma include medullary bone infarct. But in the medullary bone infarct is serpentine sclerosis and Chondrosarcoma also at the second differential diagnosis. In the following slides, I will explain how we differentiate it from the Chondrosarcoma. This is what we see in the enchondroma.
Most commonly, where does it locate in chondroma?
In the knee.
In the hand.
In the hand has a specific appearance, which is osteolytic appearance, but in the other joint is sclerotic mostly.
The most common location is in the hands, especially the hands. Okay.
Yes.
So when you see a medullary lesion in the hand, the top differential is enchondroma.
Yes. This is what we see in the hand.
What do we see? Explain.
Okay, they have an We can differentiate it from the medullary bone infarction. In the T2 we see the sclerotic يعني hyper intense margin in the enchondroma, while in the medullary bone infarction we don't see this hyper intense margin. This is what I say. In the hand, when it appears lytic lesion, not sclerotic.
And in fact, the most common representation of enchondroma is pathological fracture.
Pathological fracture,
Usually
yes.
It's not diagnosed, it's asymptomatic.
Yes, it's asymptomatic. When we see multiple enchondroma in the two syndrome, either Euler or Maffucci syndrome, but in the Maffucci associated with the venous malformation in the skin. Hemangioma, yes.
So you have Euler disease is multiple enchondroma.
And
While
Maffucci
Maffucci syndrome is
also multiple enchondroma associated with
Euler plus hemangioma.
hemangioma.
How
Yes.
do you know hemangioma? How do you see hemangiomas?
I
Soft tissue hemangiomas. I mean.
yes.
You see calcified.
Calcified fibrosis. In this multiple enchondroma, normally enchondroma rarely has a malignant transformation, but in this, when it is multiple in these lesions, in these syndromes, it has higher risk for malignant transformation. This is fibrosis, what in the red arrow, and this is enchondroma.
Red arrow enchondroma.
Enchondroma and yellow is fibrosis. Osteochondroma. Osteochondroma is a benign cartilaginous cupped bony growth projecting outward from the bone, often pedunculated, and most common benign lesion.
Benign bone.
Bone lesion, yes. Osteochondroma may present clinically as a palpable mass, which usually stop growing after skeletal maturity. The key feature for the diagnosing the osteochondroma is the continuity of the medullary bone with the host bone and the cartilage with the cartilage of the host bone.
No, cartilage is not continuous. It's just the medullary cavity or medullary inside or the cavity of the exostosis is continuous with the parent bone, and it is covered by cartilage. But the cartilage is not continuous with
cortex. I mean cortex.
bone.
Yes.
The cortex, okay.
Yes.
Cartilage, no.
Cortex and medulla. This is osteochondroma.
And it always directed
Away from the epiphysis. It's arise from the metaphysis and away from the epiphysis. This is osteochondroma.
Explain it. Let's see what's
This is
in the image.
this is MRI.
Okay.
MRI of the knee showing the exophytic bony lesion surrounded by
This is the parent bone. Yeah, this is the exophytic lesion.
this exophytic lesion, and this is the continuation of the medulla with it. Uncommon complication of osteochondroma to be a malignant transformation, but when we saw the cartilage cup more than 2 cm, and we find the pain, it's painless, but when we saw the pain without pathological fracture, so it has we increased the suspicion for malignant transformation.
Into what?
To Chondrosarcoma. Multiple osteochondroma is common in the familial, which is called exostosis, multiple hereditary exostosis, and increase in this condition risk of malignancy higher than the single.
Everything, when it's multiple. Higher risk of malignant transformation.
Another entity is Chondroblastoma. Chondroblastoma is a benign lesion located eccentrically in the epiphysis. This is how we can differentiate it from the other lesion. Is from epiphysis of the long bone of skeletally immature patient. The most commonly occur above the knee and proximal humerus. calcified chondroid matrix is present in almost all CT study, but in the X-ray only 50% we can see the calcified matrix. Chondroblastoma has a unique among all chondroid lesion that it is typically demonstrate low and or intermediate signal intensity in the T2. Other chondroid lesion has high signal intensity. Another topic is Chondromyxoid fibroma. Chondromyxoid fibroma is very rare, benign cartilaginous tumor that is typically eccentric in the tibial or femoral metaphysis above the knee, and it is rarely demonstrate chondroid matrix. It usually has sclerotic margin on the radiography and high in signal in T2 MRI. This is sclerotic margin of the lesion. Another malignant lesion in the chondroid, the most common malignant lesion in the chondroid lesion is the Chondrosarcoma. Malignant tumor of the cartilage, like osteochondroma, has multiple variety, primary and secondary. The secondary form arise from Enchondroma, when we, as we say, in the Maffucci syndrome or earlier familial Enchondromatosis, or in the Paget disease, and osteochondroma, more common familial arise from the familial osteochondromatosis. It has multiple types. The most common type of it is a conventional or intramedullary chondrosarcoma, is the most common subtype. On the imaging, chondrosarcoma typically expansile lesion in the medullary bone and with the ring or arc chondroid matrix, and the tumor cause thickening and endosteal scalloping of the cortex. This is how we can differentiate it from osteochondroma. It causes scalloping of the cortex and endosteum.
What about osteosarcoma? What does it cause?
Also, it's associated, maybe associated with the soft tissue.
How can we differentiate between osteosarcoma and chondrosarcoma, right?
Yes. Osteosarcoma with osteochondroma. How we can differentiate the chondrosarcoma from osteochondroma? Osteochondroma not cause scalloping of the cortex and endosteum scalloping.
That's what they're mixing of the terms. Osteosarcoma causes destruction and periosteal dilation and Codman's triangle and things like that. While chondrosarcoma, it causes endosteal scalloping more than destruction.
Yes.
Right?
But both of them.
Why is that? Because chondrosarcoma is less malignant.
Less aggressive, yes.
Less aggressive,
yes.
Exactly.
We have another rare type of the differentiated subtype, and other type is mesenchymal or clear cell viral. This is chondrosarcoma.
This is what?
Chondrosarcoma.
How? Explain.
Exophytic. This arising from osteochondroma.
From exostosis.
Yes. Osteochondroma.
Which is the cartilage is
more than 2 cm. Yes.
New arising pain.
Yes. This.
Of course.
This is cartilaginal cup is more than 2 cm. Okay. This is different type of it. This is what we see.
You can see the endosteal scalloping, the bony expansion.
Yes.
You can see the rings and arcs and the large
pathological
size and pathological fracture. And of course, if there was a CT or MRI, you'll see the soft tissue component.
Yes. The second topic is fibrous, the lesions of the fibrous origin. starting from with non-ossifying fibroma. Non-ossifying fibroma, sometimes called fibroxanthoma, is an asymptomatic, common, incidental radiolucent lesion in the long bone, especially in the leg, in the children and adolescents. Non-ossifying fibroma and fibrous cortical defect are thought to represent the same lesion, and the term of non-ossifying fibroma is generally when the lesion is more than 2 cm and when the lesion is symptomatic. These lesions are believed to arise from the periosteum. The radiographic appearance is usually diagnostic and demonstrates a lucent lesion with narrow zone of transition, sclerotic margin, no matrix of calcification. CT and MRI may show cortical disruption or thinning, representing replacement of the cortex by the fibrous tissue. The most undergo spontaneous sclerotic involution as the patient is reached the adolescent. At that time, I think it's called ossifying non-ossifying fibroma. Fibroma, yes. Non-ossifying called.
It starts to calcify and then it becomes ossifying fibroma.
Yes.
Really non-ossifying.
Fibrous histocytoma has benign and malignant. Benign is more rare, but malignant type is commoner than the benign. It has different name, but still malignant fibrous histocytoma is commonly used. Malignant fibrous histocytoma is the most common adult soft tissue sarcoma, rarely affecting the bone, but most commonly affect the soft tissue of the thigh and the retroperitoneum. When it is affected the bone, it is usually appear as an aggressive lytic lesion. This is non-ossifying fibroma. This is the benign type of the histocytoma, fibrous histocytoma. This is sclerotic
margin,
lytic with sclerotic, yeah.
Lucent,
yes.
Narrow zone of transition, no destruction. And with time, it will calcify. With time,
yes.
it will calcify to become a ossifying fibroma.
Yes. Fibrous dysplasia is a benign congenital non-neoplastic condition in the children and young adult characterized by replacement of the normal cancellous bones of cancellous bone of abnormal by abnormal fibrous tissue. Yes, fibrous dysplasia can affect the bone monosteotic or multiple single bone monosteotic or multiple bone polyosteotic, but when it is a polyosteotic, usually unilateral. The most frequent complication is the pathological fracture, commonly at the femoral neck. The fibrous dysplasia of the long bone tend to be central, metadiaphyseal, and often causing bone deformity such as extreme varus or Shepherd's crook deformity. This is what we see. Shepherd's crook deformity of the long bone of the femur.
It can be either single bone, monostotic, multiple bones, polystotic.
Yeah.
If multiple bones, if one limb, it's monomilic. If multiple limbs, it's polymilic. Okay. Most commonly, it is monomilic when multiple bones.
Yes.
One limb, one hand, one leg, one. Okay.
Yes. This is.
Okay. Now you can see its placement of the cancellous bone by fibrous tissue. That's what.
لا هاي غيرت المكان بس هي مكانة non-ossifying fibroma.
Okay, that's not correct slide.
Yes.
Okay.
The skull base In the skull base, the fibrous dysplasia is typically expansile and can look highly unusual on unusual on MRI. The primary differential for the expansile skull base lesion is the Paget disease, but the age of the patient is higher in the Paget disease.
The key. ليش؟ لأن fibrous dysplasia باليونج
Young age group. Paget is old age group.
And in addition, Paget disease is much more common in European countries than here. Here in the Middle East, you will never ever see a case of Paget disease. Okay? يعني don't suggest Paget disease إلا يعني you are extremely sure. Okay? In the European countries, it's much more common. Much more common. Okay? مثل عندنا here TB is very common. In the European countries, it's very rare.
We have McCune-Albright syndrome is a polyostotic fibrous dysplasia. Yeah, multiple bone affected. Precocious puberty and the cutaneous scapulae spot. We have another syndrome is Mazabrod syndrome. Yes, Mazabrod syndrome is the fibrous dysplasia and intramuscular myxoma, which tend to occur in the same region of the body. Yes.
Thank you very much.
Thank you.
Good job.